The question is, are we specific in selecting certain treatments for certain subtypes of the lung cancer that we treat, or are we treating them empirically one at a time to see the chances? And the honest answer is, yes, we are doing some selectivity, but it wasn't because we were smart. It's just because we stumbled on things. So, for example, right now we know that adenocarcinoma seem to respond better to a drug called Alimta, while squamous doesn't respond. But that wasn't even a hypothesis. That was a subset that seemed to have come out of a study. We have no clue why. We still don't know why, but we apply it. So, yes, there is some selectivity, and that's why we are now kind of pushing our pathologists to tell us a bit more about the histology, while before we didn't care because we treated them all the same. So that's one level of the fashionable term now, personalized medicine, so that you're personalizing or tailoring your therapy. A dream of oncologists, I think in the around 2000 years, was to, the year 2000, I'm sorry. Around the year 2000, when the microarrays came out, was to try and figure out who responds to drug A versus who responds to drug B, and maybe on that basis one could do more tailored therapy. But to me, again, in retrospect, things are always easier, but to me this was a very, not only ambitious, almost foolish, because you're almost saying, I'm going to go to a crowd, listen to what they're saying, and then figure out what to do with them. What we started with is this messenger RNA, which is a dynamic thing. It goes up and down, and we have a snapshot of it. And we're going to make a decision on the basis of that snapshot. And it really went nowhere. These attempts to try and use the microarray or the expression profile of tumors to try and select a subset, it really went nowhere. And when people found a signal, it was not reproducible. Because again, I think it's really looking at the noise. You're looking at the dynamic. A gene being expressed today doesn't mean it's always being expressed. It may be expressed in response to something that is happening today, but it's not going to happen later, and it may be an artifact and so on. What is much more attractive, in my opinion, is to classify or subclassify on the basis of DNA events, because these are static. Once you have a mutation, it's there. Whether you take the cell out of the body or in the body, put it in the dish, wherever you put it, it's there. And not only a DNA mutation, a mutation in the driver, in the oncogene, because that seems to be the main determinant of the cell, and we are ignoring it. So, analogy for this to explain. If you wanted to subclassify a group of people into nationalities, the most obvious thing is to look at their passport. What is your passport? You'll be wrong with me because I have a British passport, and I'm not really British. I just was born there. So you'll make some mistakes in 1-2%. But for the most part, if you go by their passport, you'll be right. Right now, we're going by their look. So you say, he looks Italian, and he looks Indian, and we are going to be mistaken left and right. And that's the problem, lack of specificity. The naming process, we call it adenocarcinoma. What does that mean? These cells make a gland. So what does that mean exactly in terms of therapeutically? Should we target them with this drug or not? It means nothing. It just means they are still getting together, and it looks like a gland. It's not even a gland. It just, it looks a little structure. While squamous looks like the skin. It's almost like layers. It's morphology. It's looking at Dr. Barton and says, Holland. Probably he's from Holland. But I could be right. Our could be wrong, because I'm not looking at the real thing, the static thing, his passport. We have a passport. It's one per tumor. It's DNA. You can look at it in a biopsy that is taken 10 years ago, but we're ignoring it. Why? Because there's no convention. We don't organize ourselves and say, stop the nonsense. Let's look at things as they are. Why are we like that? Because we grew up in this nice system where we don't critique each other. We don't interrupt each other. We don't say, what are you saying? We just say, I didn't like that, and we walk out of the room. So we propagate mistakes. It is very difficult to change a wave of ideas, even if you have the compelling reason, because people are not on the same wavelength. We don't have this organization to say, this is not correct, let's just use the other method. There's very little dictatorial power in science to say, this is what needs to be done, and you end up paying the price in things being very slow. So the term right now, personalized medicine is very fashionable, but really if you look at it, what are we talking about? We're not talking about intellectually smart, thoughtful ideas. Usually we stumbled on something, we don't know exactly why, but we're going to use that term so that we can sell it better to the population.